Hello again. This is Dr. Stokes with Bread and Butter Primary Care. Glad to have you back for another discussion. Today we're going to be talking about hypertensive urgencies and hypertensive emergencies. So these are times when people's blood pressure are too high for comfort and something else needs to be done quickly, sometimes in the office, sometimes they need to be sent elsewhere. So how do we define these two things? So there's a couple different ways. So we're going to start with the top and work our way down. Hypertensive emergencies. I like to think of two general times when you want to consider a patient to be in a hypertensive emergency. This means, obviously with the word emergency, something needs to be done immediately. So the blood pressure is a big enough problem right now that it needs to be brought down, it needs to be evaluated and managed in a short-term basis. So two different situations to look out for. One is just a pure number issue. Blood pressure above 220 systolic and above 120 diastolic. If you've got people coming in and they're in the 230s, 240s, 130s on the bottom, that blood pressure is just too high. There are a few people who have lived up there for a long time and they may be okay, but it's not worth the risk anymore. So for me in my practice, if I've got someone there, their blood pressure's coming in with a systolic above 220, a diastolic above 120, even if they're feeling okay, even if they're not having any symptoms, that's someone that I'm going to address right then. There's a few things you can do in office to bring the blood pressure down, but I want to in general caution against that depending on what type of office you're in. If you're connected to a hospital, maybe you have an urgent care, maybe you have a place where a patient can be watched over a period of hours. In that case, you may be able to do more than in more of a classic primary care office. In my office, we don't have a place to watch patient for hours on end. We don't have any sort of IV supplies to be able to do any sort of intravenous treatments, and so we don't have all that much we can do. Probably the most common thing I see used in primary care offices to bring a blood pressure down right away is clonidine. Clonidine is a fast-acting medication. It can bring the blood pressure down fairly quickly. But remember, it's temporary. If you've got someone in your office and their blood pressure is 230 over 130, sure you can bring it down, but what happens when that wears off? It's going to come right back up. And with clonidine in particular, it could even rebound to a higher level. So artificially bringing the blood pressure down with some clonidine just so you can send them home is not a good idea, because it's going to go back up and they're not going to be somewhere where they can get help if they need it. So if the number's above 220 systolic, if it's above 120 diastolic, you're playing with fire in that range. Now, every doctor has their own comfort level as to what they've been trained to do and what they're comfortable with. For me, doing bread and butter primary care, above 220 and above 120 is just too high. I'm going to be finding a way to get that person to a place where they can have their blood pressure lowered while being continuously monitored to make sure that nothing happens. So that's number one. Numbers are just too high. Number two is high numbers plus symptoms. So this would be someone whose blood pressure is less than 220 systolic and less than 120 diastolic, but is symptomatic. So usually anyone who's above 180 systolic and above 110 diastolic but has symptoms, and especially signs of end organ damage. That's a key term when you're talking about hypertensive urgencies and hypertensive emergencies. Anytime there's a sign of end organ damage, end organs being kidneys, extremities, and even brain possibly. So if you've got a person who has a blood pressure, let's say of 190 over 110, and they feel fine, they have no symptoms, they're like, doc, I feel great, there's nothing wrong, that's a hypertensive urgency because their numbers are high, but they're not having any signs of end organ damage. They don't have a severe headache, they don't have any symptoms, they don't have anything going on. That can be managed closely with close follow-up and probably home and outpatient care. That same person, you've got that same person with a systolic of 190 or anything above 180, the diastolic's above 110, they've got a massive headache. They've got blurred vision. They're not urinating. They say, hey, I haven't peed in 24 hours. They've got numbness in an extremity. They've got high blood pressure, plus there's something going on. that puts it up to emergency. Okay, so above 220 and 120, boom, game over for me at least. In an outpatient setting, that person needs to have monitoring, they need to have treatment. Above 180, 110 with symptoms or signs of end organ damage. Now, some of the end organ damage isn't apparent on physical exam. It's only apparent with lab findings. So kidney function, if the creatinine comes back really high. And that's another thing, at least in my office, I can't get a creatinine in less than 24 hours. So if I order that and we draw it in office, I will get the result the next day. And so those are things you have to consider. How fast can I find out if there's end organ damage? And so you have to be careful with those types of information. So I've seen a couple things. I mean, usually I haven't seen people who have 230s and 120s and they just get sent home on lisinopril. That usually doesn't happen. Most often, people actually tend to send people out to the emergency room when it's a hypertensive urgency and it's not an emergency, which can be understandable. I mean, the idea of playing it better safe than sorry does make a lot of sense in medicine, and I would never fault someone for doing something they didn't feel comfortable doing. But in most cases, if they're less than 220 and they're less than 120 on the bottom and they are asymptomatic, they feel fine, there's no symptoms, there's no reason to think that they have any end organ damage, that person can be started on some, oftentimes dual therapy, high dose of an antihypertensive, and you're going to recheck them in a couple days. Here, go home, here's some medicine, take this medicine, and come back in 3 or 4 days. Let's check and see where you're at. Maybe they have the ability to monitor at home and they can check and let you know as well. Always with ER precautions expressly given to the patient if you should develop headache, if you should develop chest pain, if you should develop numbness in an extremity, confusion, symptoms, anything like that, then they would know that they need to seek attention. So most blood pressure management is pretty straightforward. There's no huge rush. You can work on it and get it done in weeks to months. But once you get into these two categories where you have a hypertensive urgency and a hypertensive emergency, that needs to be addressed in a much shorter time scale. Emergencies immediately, urgencies hours to days. Okay? So again, just to review here at the end, blood pressure higher than 220 systolic, higher than 120 diastolic. For me, that's game over. Hypertensive emergency, they need to be seen somewhere where they can get immediate attention and monitoring. If they're between 180 and 220, or between 110 and 120 on the bottom, and have symptoms, headache, chest pain, vision, numbness, lack of urination, that's also an emergency. That person needs to be seen right away. They need to have labs that can come back in the matter of minutes to hours, not days. If they're in that 180 to 220 and 110 to 120 range, but they have no symptoms, they feel fine, they have no signs of end organ damage, then you can go ahead and treat that person as an outpatient, close monitoring, good ER precautions as to when they should seek help. I hope that's helpful for next time you have someone coming in and their blood pressure is a little too high for comfort, to help guide your decision as to what to do next. Have a great day. This is Dr. Stokes for Bread and Butter Primary Care.